Welcome back to The Explainer. Today, we are stepping right into the resuscitation bay to tackle one of the most high-stakes, time-critical emergencies in all of medicine: shock. Picture this: a crashing patient rolls through the doors. The clock is already ticking towards irreversible organ failure, and honestly, hesitation just isn't an option here. Our overarching mantra today: treat first what kills first. In this critical care explainer, we're going to build your cognitive framework for rapidly recognizing and managing shock, armed with the absolute latest 2025 guidelines. Here is our roadmap for today. 1. Defining the threat. 2. The foundation of management. 3. The 4 classes of shock. 4. Immediate targeted therapies. And 5. Common pitfalls and golden rules. Okay, Section 1. Defining the threat. Let's dive into this, because we need to correct the single most dangerous misconception in critical care right out of the gate. Shock is a life-threatening state of circulatory failure leading to cellular and tissue hypoxia. The absolute core axiom here: shock is tissue hypoperfusion. It is not just hypotension. You can absolutely have normal blood pressure and still be in shock. Before that pressure ever drops, you need to look for the subtle clinical signs of this cellular starvation: altered mental status, decreased urine output, cool, clammy skin, or mottling. If you're waiting around for the blood pressure to drop, you're already falling behind. The effects of this hypoxia are initially reversible, but left unchecked, they cascade like falling dominoes into irreversible end organ dysfunction.
Moving on to Section 2, the foundation of management.
So the moment that patient arrives, we always fall back on the ABCDE approach. This is your rock-solid foundation. A is airway. Ensure patency and protect it, meaning intubate if their Glasgow Coma Scale is 8 or less. B is breathing. Slap on supplemental oxygen and monitor that SpO2. C is circulation. This is huge. Immediately establish 2 large bore IVs or intraosseous access, start your fluid resuscitation, and seriously feel their skin to assess perfusion. D is disability. Check mental status, and please do not forget to check a blood glucose. Finally, E is exposure. Do a full physical exam to hunt for the hidden source of the shock. And remember, these aren't step-by-step sequential actions. They are happening simultaneously in those precious early minutes.
To formalize that golden window, expert consensus gives us the MINUTES acronym for the initial 30 minutes of care. Think of it as your strict life-saving checklist. M, maintain those ABCs. I, identify and treat the root cause. N, never ever delay antibiotics for sepsis. U, use ultrasound, specifically bedside POCUS. T, titrate your fluids and vasopressors. E, evaluate the patient's response to your therapies. And S, seek specialist help early. Memorize this bundle. It's designed specifically to catch shock before it crosses the line into irreversible territory.
Section 3. The 4 classes of shock. There are 4 main classes of shock, and honestly, the best way to visualize them is like a giant plumbing system. First up, distributive shock, which covers things like sepsis and anaphylaxis. This is a pipe problem. Massive vasodilation means the pipes are just way too wide for the fluid inside. Clinically, these patients initially present warm and flushed, which totally sets them apart from the other 3 classes, where folks are typically cool and clammy. Second, cardiogenic shock. This is straightforward pump failure. The heart itself just can't pump adequately. Third, hypovolemic shock. This is a tank problem. Whether from massive hemorrhage or severe dehydration, the tank is empty, leading to a huge drop in cardiac output. Finally, obstructive shock. This is a physical blockage in the system, literally stopping blood from moving forward. Now, what's really interesting here is how the 2025 ESIC guidelines are completely revamping our monitoring strategy. We are officially ditching static measures like central venous pressure. Instead, you've got to use dynamic indices like pulse pressure variation to figure out if they actually need fluids. Plus, you need to rely on serial lactate measurements to actively steer your resuscitation and prioritize bedside echocardiography as your absolute first-line imaging. It is a game changer for rapidly figuring out cardiac function and volume status.
Section 4, immediate targeted therapies.
65. Burn this number into your brain. If fluid resuscitation fails to restore adequate perfusion, this is your magic target. Your mean arterial pressure, or MAP, needs to be greater than or equal to 65 millimeters of mercury. And to get it there, norepinephrine is your absolute first-line vasopressor for both septic and cardiogenic shock. You can always add vasopressin as a backup if you're maxing out, but norepi is the MVP. When it comes to the fluids themselves, your choice matters immensely. The goal is to rapidly refill that intravascular volume. Balanced crystalloids like Ringer's lactate or plasma light are preferred over normal saline. Why?
Well, we really want to avoid hyperchloremic acidosis, which can totally wreck a complex resuscitation. The standard move here is a rapid 20 to 30 milliliters per kilogram bolus, and then you reassess. Remember, dragging your feet on fluid therapy leads straight to irreversible shock. Let's zero in on septic shock specifically. The stakes here are just staggering. Mortality hits 40% or more when shock sets in. Your immediate priorities? Secure the airway, get that access, and push up to 30 mils per kilo of balanced crystalloids. But here is the critical timer you're racing against. Antibiotics absolutely must be administered within 60 minutes of a physician order. Every single hour of delay drastically drives up mortality. Follow that up with aggressive source control, like, say, draining an abscess, and get that norepinephrine going if the MAP is stubbornly sitting below 65. Switching gears to cardiogenic shock, which is primarily caused by massive acute heart attacks. We are seeing a massive paradigm shift in how we approach advanced shock stages. The 2025 ACC and AHI guidelines just completely shook up mechanical circulatory support. Thanks to a decade of data from the Danger shock trial, microaxial flow pumps, like the Impella device, have been upgraded to a Class 2A recommendation for select patients. Get this, the trial showed the Impella reduced 180-day mortality by almost 13% and gave patients roughly 600 additional days of life. On the flip side, the intra-aortic balloon pump and VA ECMO have actually been downgraded to Class 3, meaning we really shouldn't be using them routinely anymore. Now, what about hypovolemic shock? Specifically, let's talk trauma and hemorrhagic shock, which is still the leading cause of preventable death in injured patients. The strategy here is pure damage control. First, stop the bleeding. Direct pressure, tourniquets, pelvic binders, whatever it takes. And unlike sepsis, here we actually want to limit crystalloids. Don't drown them in saline. Instead, you trigger a massive transfusion protocol early using a 1-to-1-to-1 ratio of packed red blood cells, fresh frozen plasma, and platelets. We also use permissive hypotension, meaning we let the blood pressure ride a little bit low so we don't accidentally blow out any fresh, fragile clots forming at the injury site. Our final class is obstructive shock, the ultimate mechanical emergency. The one and only goal here is immediate, aggressive relief of the obstruction. If it's a tension pneumothorax, you're doing a needle decompression right in the second intercostal space, followed quickly by a chest tube. If it's cardiac tamponade, you're doing an ultrasound-guided pericardiocentesis to drain that fluid. And for a massive pulmonary embolism, you're moving straight to thrombolysis or a surgical embolectomy. Bottom line, fix the blockage, fix the shock. Let's bring it all home with Section 5, Common Pitfalls and Golden Rules. These are the traps that literally cost lives. First, getting tunnel vision and failing to consider the differential diagnosis. Assuming it's one type of shock without ruling out the others. It's totally possible to have mixed shock. Second, dragging your feet on antibiotics and sepsis. Third, under-resuscitation, just being too timid with fluids or blood. Fourth, and this is crucial, failing to calculate the shock index. Just divide the heart rate by the systolic blood pressure. Simple math. But if that number is 1.0 or higher, it is a massive red flag for hidden shock, even if their blood pressure looks totally fine on the monitor. And finally, the most dangerous pitfall of all. Focusing entirely on blood pressure while completely ignoring the real signs of perfusion like lactate, urine output, and mental status. So, I want to leave you with this exact question to ask yourself the next time you are standing at the bedside. Are you treating the blood pressure or are you treating the perfusion? Remember, shock is initially reversible, but only if you recognize it early and treat it aggressively, using a structured, systematic approach. Treat first what kills first. Master the guidelines, watch the perfusion, and go save lives. Thanks for hanging out with me for this explainer, and keep learning.
Thank you for watching this edition of the Emergency Medicine series. If you found this session valuable, please click the subscribe button below and turn on notifications to never miss an episode. Stay safe. Keep learning, and I'll see you in the next lecture.